Hi there. Good evening, everyone. Good evening, my friends in Middle East. It's our pleasure to have all of you today with us, or tonight. It's 14th of September, 2021, and it is indeed my great honor to warmly welcome you to another chapter of Menaso Cerebrovascular Grand Round tonight. Tonight, we will have two distinguished speakers, one from the region, Professor Akhtar, and Professor Götz Thomalla from Germany. Before we start, I would like to remind all our attendees that if you have any questions, you can use the Q&A bar or box below to put all your questions, and we will be more than happy to answer these questions with our speakers at the end of the sessions. This session will be almost 90 minutes, where both of the speakers will go through update in the field of stroke. Also, the CME will be sent after 2 weeks from this session. To mention that this webinar is supported by World Stroke Organization and American Stroke Association, and we are glad that we have been having a success year through Menaso for this webinar. Just to remind you that in November, as you saw on the announcement before we start, that the Menaso Congress will be this year in Bahrain, which will be hybrid. So all of you are welcome to join us physically or through the webinars that going to be sent through the links that when you register for the Congress. No further delay, I would like to introduce our distinguished speaker today, Prof. Götz Thomalla. Prof. Götz Thomalla has a very long CV that I can go through. He had more than hundreds of publications in the field of stroke. He got his degree of Prof for imaging-based clinical stroke research, and he's a senior neurologist at Department of Neurology in University Medical Center of Hamburg. Also, he's a fellow of European Stroke Organization and member of the steering committee of the Virtual International Stroke Trials Archive Imaging, VESTA. He received multiple awards at the level of Germany and Europe. At the same, he has more than 20 years of experience in the field of neurology, and as I said, he had multiple publications in a peer-review journals. Tonight, he's going to speak about intravenous thrombolysis in the extended time window. Welcome, Prof.
So thanks a lot for this very kind introduction. Hello, everybody, dear colleagues. I'm more than happy to be able to talk about this interesting topic now in the next roughly half an hour, and later on to answer questions. Now, what I'm going to talk about is intravenous thrombolysis in an extended or late time window. And I would like to start with a clinical case. So just imagine you have a 74-year-old male patient who woke up at 7:30 with a hemiparesis in the fascia. And then he's referred to your hospital at maybe 8:15, moderate to severe neurological symptoms, so NIHSS score of 12. What would you do with such a patient? Now, just a couple of years ago, we would have actually had no chance to offer this patient a specialized effective treatment because there was no evidence available. But this has changed, luckily, over the past years. And I just mentioned here 4 landmark papers of clinical trials which provided evidence for treatment in the late and unknown time window. And as you can see here, it's about the late time window, so 6 to 24 hours, 6 to 16 hours, or the unknown time of onset. And it's all about imaging-guided treatment. So either mismatch, MRI-guided, perfusion imaging-guided treatment. And that's what now really will be the topic for the next minutes to talk about. So if we think about time windows for stroke reperfusion treatment, we have, of course, the early time window within 4.5 hours of known symptom onset, which you all know, and where thrombolysis has been established now for some years. And then we have those patients arriving later or with no known time window. And actually in this time window, we will need to rely on imaging. to identify patients that may benefit from reperfusion treatment. This slide briefly summarizes the evidence and the situation from the known time window thrombolysis. And you all know patients have to have an acute stroke with a disabling deficit, no spontaneous improvement. We have to exclude hemorrhage, usually with non-contrast CT. And of course, we need to check that there are no contraindications like any condition associated with increased risk of hemorrhagic complications. Blood pressure needs to be controlled. And then actually there's a quite uniform recommendation from all national and international guidelines to give standard dose TPA 0.9 milligram per kilogram body weight, which is only different in Japan where a lower dose is used. And then we know that thrombolysis significantly reduces the number of patients who suffer from persisting neurological deficits after stroke. And we also know that time plays a major role. So time is brain is a well-known slogan. And you all know these results, a pooled analysis of the large thrombolysis trials, where you can see here the odds ratio for improved outcome with treatment, starting somewhere here, which decreases over time. Down there is the time in hours from symptom onset, and somewhere around 5 hours from symptom onset, there is no significant benefit if patients are just selected by clinical criteria and plain CT. But we also know that it's a very effective treatment across all subgroups. So independent from age, no matter if patients are beyond 80 years of age or younger, and no matter if they have severe symptoms or not so severe symptoms, this is what you can see here. There's always a clear benefit of intravenous thrombolysis. But if we go beyond 4.5 hours now, we have to rely on a more refined imaging. And this is what we mention if we talk about the tissue window using instead of a time window, because we have to use imaging as a biomarker that identifies patients likely to benefit. And there are two major approaches. The first one is on the left shown here, imaging as a biomarker of tissue that can be saved by thrombolysis, so the so-called penumbral imaging. And we can use either MRI with diffusion-perfusion mismatch as shown here, or perfusion CT as shown down here. And the second approach is to use MRI with a DWI flare mismatch as a surrogate of lesion age and irreversible tissue damage. And I will briefly talk about the two approaches now and about the data underlying the new recommendations. So we all know that stroke is a dynamic process with a small infarct core shown here on the upper side in red, which increases over time. And we can use imaging, penumbral imaging, to capture a situation like here, where there's only a small infarct core shown here by small DWI lesion, surrounded by a large perfusion area, so tissue that is likely to proceed to infarction if the vessel doesn't get reopened. And this is an example of a successful thrombolysis case. So all here in green is the mismatch, so the area with severe hyperperfusion but no final infarct. And this all could be saved if you look at the follow-up image here, where the final infarct is as small as the initial DWI lesion after successful reperfusion. And this is how these images look like in clinical practice if you use, for example, a software to automatically analyze perfusion and diffusion maps. You can see here in purple the small diffusion lesions of the small infarct core, and in green the larger perfusion deficit area. You can see there's a clear mismatch. This patient would very likely benefit from reperfusion treatment. Now, the second approach is to use MRI as a marker of lesion age, and what is the underlying pathophysiological assumption is shown here. So these squares are meant to represent cells, and we know that within the onset of acute ischemia, within minutes, there is a cell swelling, cytotoxic edema. And this can be seen, this is the underlying pathophysiology underlying the DWI signal. So we can see this on MRI within minutes of ischemia. But we don't see this in FLAIR usually. In FLAIR, we only after hours, we see the net water uptake in tissue and see the stroke lesion here now as a hyperintensity, which is actually the same mechanism which we see in CT as a hyperattenuation. But if we have a pattern like this, diffusion-weighted image lesion, but no clear hyperintensity in the corresponding area in FLAIR, this is called a DWI FLAIR mismatch, and this patient is likely to be within the first hours of stroke where he's likely to benefit from thrombolysis. And this was the concept that we used in the wakeup trial to identify patients and include patients, randomize patients in our trial. So now I've briefly shown the underlying concepts. Now as to the trial data, the EXTEND trial was the first successful trial for thrombolysis in the extended and unknown time window based on penumbral imaging. That's why it's a very important study. It used intravenous alteplase with a standard of care with no thrombolysis within a late time window up to 9 hours or unknown time of symptom onset. If patients had a penumbral pattern on MRI or CT perfusion, which was defined as a perfusion lesion and a Tmax maps with more than 6 seconds delay, versus infarct core, which was identified on perfusion imaging or DWI, on perfusion CT or DWI, and there had to be at least a certain amount of tissue that could be saved, and the infarct core was not allowed to be too large. The trial randomized 225 patients. You can see here median NHS was 12 or 10 in both groups, and there was a significant benefit, a higher number of patients with a favorable outcome in the alteplase group, with an adjusted risk ratio of 1.44 to achieve a better outcome. You can see down here the modified ranking scale bars, and you can see here in the alteplase group, the patients with low numbers, the low scores on the modified ranking scale were more frequently. So this is the first trial demonstrating that IVTPA is efficient and saves patients from disability if it's based on penumbral imaging beyond the first 4.5 hours. What is also of interest in this trial is that about 2/3 of these patients had unknown time of symptom onset actually. So rather a smaller proportion had a late time window stroke, and that 70% of patients had a large vessel occlusion. So patients that we now would like to treat with thrombectomy, but the trial shows that IVTPA also works in these patients. All the authors of EXTEND, ICIS-4 and EPITHET provided a meta-analysis of the data from all of their trials, which combined all patients treated with a late and unknown time window based on perfusion imaging. And you can see here 414 patients were randomized in these 3 trials, and the results were largely reproduced with an even better treatment effect, an odds ratio of 1.86 for improved excellent functional outcome with intravenous thrombolysis. And this effect was very clear in patients which had a perfusion mismatch as shown by the automated analysis, but there was no clear effect in those patients which had no obvious perfusion mismatch, which again demonstrate that the approach of penumbral imaging works. Of course, the rate of symptomatic intracranial hemorrhage was higher with alteplase, like in all thrombolysis trials, but the net benefit also includes these patients. And as you can see here, the modified ranking scale overall shows a clear improved functional outcome in patients treated with IVTPA. And again, subgroup analysis showed a consistent effect across all important subgroups. Now, what about thrombectomy? We have these 2 landmark trials, DAWN and DIFFUSE-3, which both used extended imaging to identify patients likely to benefit from thrombectomy in a late or unknown time window. The clinical imaging mismatch in DAWN, so the patients had to have severe symptoms, but only a small infarct core. And the vast majority of these patients had an unknown time of symptom onset, and the treatment benefit was enormous. You can see here 49% with 13% of patients with an independent outcome. If you compare the outcome here in the bars of the modified ranking scale, there's a very clear improved outcome in the thrombectomy group up here. And this is very much the same for DIFFUSE-3, which used tested thrombectomy with the standard of care up to 16 hours in patients with a penumbral pattern on MRI or CT. Again, the majority of patients were in unknown time of symptom onset, and the effect was very much comparable. So this is a highly efficient treatment, opening a large vessel if the patients have a beneficial pattern on imaging. Now, there was another trial, the wakeup trial, which used the second approach, MRI, to identify patients within in a very early time window, DWI flare mismatch, so a pattern like over here, to randomize patients in an unknown time of symptom onset to treatment with TPA or placebo. Primary endpoint was the same as in all thrombolysis trials, modified ranking scale 0 to 1 at 90 days. And we randomized all in all 503 patients, and the median NGS was 6, so rather moderately severely affected stroke patients. And I would just like to show you a couple of images that illustrates this approach to imaging. So you can see here on the left side a clear lesion on the DWI, also here a small embolic lesion in the periphery of the MCA territory, but no marked hyperintensity on flare. So this is a clear DWI flare mismatch. And again here, a clear partly MCA stroke, no parenchymal hyperintensity on flare. Both patients were randomized in the trial. They meet this criteria of DWI flare mismatch. Whereas these two patients, as you can see here, again, DWI lesion, but a very closely matching lesion on flare. And also here, a DWI lesion showing the early ischemic signs on the MRI, but again, parenchymal hyperintensity on flare. So these patients are likely to have strokes that last longer than 4.5 hours. They were not randomized in the trial. Now the results were very clear. In those patients with an unknown time of symptom onset who had this DWI flare mismatch pattern, treatment with intravenous thrombolysis resulted in better functional outcome. And you can see here the results of 53% favorable outcome as compared to 41.8%, odds ratio of 1.61. And if we looked at the distribution of outcome across the entire MRS scale as shown here, the odds ratio is very much the same, 1.62. And you can see here the number of patients having a very good outcome, MRS 0, 1, or 2, was clearly higher in the population treated with intravenous thrombolysis. So the main conclusion was that MRI-based intravenous thrombolysis is effective for unknown onset stroke if they show this pattern of DWI flare mismatch. And this in a population which with a median NGS of 6, which usually does not qualify for thrombectomy. But we also had patients with large vessel occlusion in wakeup. So about 1 in 5 patients, 98 altogether, had a large vessel occlusion. They had a higher NHSS value. And you can see here, this is the analysis in this subgroup. And there was also a clear benefit of intravenous thrombolysis in the subgroup of patients with large vessel occlusion. None of them received thrombectomy. So this was done at a time where thrombectomy was not clinical practice in most European countries. And you can see here we almost doubled the rate of patients with a favorable outcome, although overall the rates of patients with good outcome in this population, of course, were lower. Now, following this, we also performed a meta-analysis, including data of patients with an unknown onset stroke from wakeup, from the EXTEND study, from FORCE, which was a Japanese companion trial to wakeup, and from ICIS-4. And we were able to identify 843 patients treated in all these trials which had an unknown onset stroke. And this is the result for this meta-analysis. So we have 47% of patients in the alteplase group with a good favorable outcome as compared to 39%, so an absolute increase of 8%. And this translated into an adjusted odds ratio of almost 1.5. So again, a clear, and as you can see here, significant benefit in this larger population. And this was also true for the secondary outcome of looking at the entire MRS distribution. Adjusted odds ratio of about 1.4, significant. You can see here again the individual outcomes which show a benefit of treatment with alteplase as compared to controls. Now we've talked about large vessel occlusion, but another question that comes up is what is about those patients with a small lacunar stroke? Can we treat these also with intravenous thrombolysis? And there has been some discussion about this in the past years, because people tended to say, well, there are different mechanisms underlying lacunar stroke. There's not embolic strokes, no thrombus, but sort of changes in the arterial walls of the very small vessels, and they might not benefit from intravenous thrombolysis. Now, as we had MRI available in the patients included in wakeup, we had the opportunity to look at this, and we identified 108 patients with a lacunar stroke according to the criteria that have been suggested earlier in the STRIVE group, and that were treated in the trial. As you can see here, they had an even lower median NGSS, which of course is clear because lacunar stroke usually mostly don't have the very severe stroke symptoms. You can see here just 2 examples of a lacunar thalamic stroke and the lacunar brainstem stroke. Both of them were treated in wake-up, and the follow-up MRI showed, confirmed the infarct on the FLAIR image. So now we took a look at this subgroup, and again, we saw a comparable treatment effect in lacunar stroke as compared to the overall and to the non-lacunar strokes, with a favorable shift towards better functional outcome in 90 days, with an adjusted odds ratio of 1.9. And of course, due to the small subgroup, this was not significant, but the trend was very clear, and the treatment benefit, the absolute increase of patients with a good outcome, was very much the same as in the overall population, as you can see here. And of course, you can see that overall the outcome of these patients was much better than in the entire population, but nevertheless, TPA clearly improved outcome in these lacunar stroke patients. And so yes, we can use MRI to guide intravenous TPA in lacunar infarcts of unknown onset. This is a clear message from this trial. And yes, IV TPA works in lacunar stroke. So now, how should you proceed in clinical practice? I think that's an important question, of course. And now we have a lot of information from the trials that informs us how we can guide our treatment by imaging. And we should decide on the imaging that is used on the treatment based, of course, on the time window that patients are presenting in. So if we have a patient in a known clear time window of within 4.5 hours, the situation is very clear. Then we just need to do plain CT to exclude hemorrhage, to guide thrombolysis, and we need to do a vessel imaging, of course, because we need to identify those patients with a large vessel occlusion that we would like to treat with thrombectomy, so CTA, or we do MRI. And then we give IV TPA according to licensing criteria, or we give mechanical thrombectomy according to the results from the big 5 T trials and according to guideline recommendations in all international guidelines. So this is important. And if we do MRI in these cases, we need to make sure that we have a sequence in MRI that excludes hemorrhage, so to make sure that we don't overlook intracranial hemorrhage. But what's the case in the known late time window? Then we need more imaging. We need to do CT perfusion or MRI with penumbral imaging, because we need to rely on the tissue-based definition of tissue at risk of infarction to guide intravenous thrombolysis according to the EXTEND trial, and as well to guide mechanical thrombectomy according to DAWN and DEFUSE-3. And of course, the time window for intravenous thrombolysis would only be up to 9 hours based on EXTEND, while for thrombectomy it would be up to 24 hours. And in unknown onset stroke, we have 2 different possibilities. We can use MRI, and this would be the first choice, because in MRI, we can both do the DWI flare mismatch as well as penumbral imaging to identify patients for intravenous thrombolysis, as well as to guide mechanical thrombectomy based on DAWN DEFUSE-3, and to guide intravenous thrombolysis based on wakeup or EXTEND. Or if MRI is not available or patient has contraindications, we can do CT perfusion, and use penumbral imaging to guide IVTPA according to EXTEND, and again according to DAWN and DEFUSE-3 to guide mechanical thrombectomy. The advantage of MRI, that's why I suggested as a first choice, is that only MRI will allow evidence-based treatment with IVTPA in the smaller infarcts or lacunar strokes which do not have a penumbral pattern. And I come to this in now at the end of my talk in the clinical case. So to come back to the patient that we have encountered at the very beginning, as you may remember, a wake-up stroke coming early to your hospital with a severe stroke symptoms. Now, if we now in this patient do a CT with CT perfusion, CTA, it's likely that we identify no intracranial hemorrhage, but he would have a sort of limited infarct core aspects. If you use the aspects score to grade the early ischemic signs of 8, so not so large infarct sign. If we measure the core and perfusion imaging, it would be 15 mils. So we have a large perfusion core mismatch, and we see M1 occlusion. Now, with this findings based on EXTEND, we would immediately start intravenous thrombolysis, and we would refer the patient to the catheter lab to do thrombectomy, both according to DAWN and DEFUSE-3 criteria, because the patient would meet criteria from both of the trials. And it would look very much the same if we do MRI. Again, we would not see an intracranial hemorrhage. There would likely be a small diffusion-weighted imaging lesion, no marked parenchymal hyperintensity and flare, so the patient would meet wake-up criteria, having a D-double flare mismatch, but at the same time, he would show a large perfusion core mismatch coming along with this M1 occlusion, and we could guide IVTPA either based on extent or on wake-up criteria, and again, do thrombectomy according to Dawn or diffuse 3. So based on the available evidence, we will now have evidence for reperfusion treatment, both intravenous thrombolysis as well as thrombectomy, available for such a patient, which you would not have had 3 or 4 years ago. And this is really a game changer for treatment of these patients. But consider very minor changes in the clinical setting, and that's why I come back to the slight differences in imaging. If this patient's now, the patient, or a twin brother of this patient will present with a rather small stroke, NHS of only 5. Again, we do CT perfusion with CTA, so there's no intracranial hemorrhage. Aspects would be 10, so we don't see any ischemic signs, early ischemic signs of infarction. There's no perfusion lesion, no perfusion core mismatch, no visible vessel occlusion. So based on these criteria, on extent criteria, we could not offer IVTPA to this patient because he would not meet these criteria. We are not even sure if it's an ischemic stroke because we don't see anything in imaging. And of course, it's not no patient who qualifies for thrombectomy. But if in such a patient we do MRI, we might see a small lacunar DWI lesion, which is not visible on CT. Again, there is no marked parenchymal hyperintensity and flare, so the patient has small lesion, but he has a DWI flare mismatch, no perfusion core mismatch, no vessel occlusion. But based on wake-up, we would be able to give IVTPA to this patient. That's why I would suggest, especially in those patients with a small, with a minor stroke or moderate stroke in the unknown time window, I would suggest MRI as a first choice for imaging, because we could see these lacunar stroke and treat these with IVTPA based on the available evidence. So with this example, I come to the end of my talk, and I would like to conclude that imaging-guided reperfusion treatment in the extended and unknown time window is ready to be used in clinical practice now. The evidence is there. We now need to make sure that we can bring this evidence into clinical practice and treat our patients based on these criteria. We can use penumbral imaging with CT or MRI, CT perfusion MRI, to guide mechanical thrombectomy in the late time window, up to 24 hours, and also in the unknown time window. This is based on the Dawn and diffuse 3 criteria. We also can use penumbral imaging with MRI or CT perfusion to guide intravenous alteplase, intravenous thrombolysis in the late time window up to 9 hours, and in the unknown time window. And at the same time, we can use MRI with the DWI flare mismatch approach, as it was done in wake-up, to guide IVTPA in the unknown time window. And we can do this even in mild to moderate and lacunar stroke patients. So that's why, as I said before, MRI would be preferred if you have it available, preferred imaging modality in mild to moderate stroke. But of course, you can also use CT CT perfusion to guide treatment in late and unknown time window based on extent and the thrombectomy trials. And as a final conclusion, I would say, of course, we do not need to do extended imaging in all stroke patients. So in those with a clear stroke, clear time window, clear stroke symptoms, we don't need to waste time. We need to be fast. CT perfusion, plain CT and CT angiography is enough. We don't need CT perfusion here. But we need to have extended stroke imaging available in all stroke centers 24/7 if we want to offer our patients the effective treatment in late and unknown time window based on the recent evidence. Now with this, I'm at the end of my talk, and I'll be very happy to answer questions later on during the meeting. Thanks a lot.
Thank you, Prof. Thank you, Prof. Thomalla. A very nice review. Many articles and paper and study that you went through, going from wake-up stroke to unknown time, minor stroke, large stroke, low NIH stroke, CTA, CT perfusion, and MR perfusion. And I'm sure that there will be many questions. So I will ask all our audience to please drop your question in the Q&A box. And sure, by the end of the session, Professor Thomalla and our next speaker, Dr. Naveed, will answer your questions. Thank you, my friend. So let us to move to our next speaker, Dr. Naveed Akhtar from Qatar. Dr. Naveed is very close friends to Suhail. I'm so glad. Hi, Naveed.
Hi.
Long time didn't meet. Alaikum assalam, sir. So Dr. Naveed is a senior consultant neurology at Hamad Medical Corporation in Doha, Qatar. And at the same time, he's assistant professor at Cornell Medical School in Qatar. And he's also a faculty member of Qatar University in Doha. He's an active teacher. He's teaching many fellows, residents, and in Arab board examination. Dr. Naveed received many awards during his journey in Qatar, which he's going to give us part of that journey. Dr. Naveed has more than 92 publications in the field of neurology, and he's a fellow of European Stroke Organization and a fellow of American Academy of Neurology. Dr. Naveed is going today to speak about experience of Hamad Medical Center stroke service in Qatar with a COVID-related stroke during pandemic. The stage is yours, Dr. Naveed.
Thank you, Dr. Suhail, very much for this kind introduction. And I really enjoyed Dr. Götz' compilation of the latest evidence on acute stroke treatment beyond hours. It is really nice information, updated information. Today, and thank you so much, Dr. Suhail and Menaso committee for inviting me. As we all know that pandemic has really changed our attitude and behavior, which is evident on this Zoom presentations meetings as well. As compared to along with the rest of the world, MENA region has been significantly affected by pandemic as well, and we experienced a lot of COVID-related stroke patients. So I thought that it would be better to present on what is our experience with the pandemic and COVID-related stroke patients. So this is the outline of my presentation. I'll talk about what happened with the patients with the COVID-related stroke here. We will talk about the stroke service at how stroke service at Qatar and Hamad Medical Corporation dealt with it. I'll give you a couple of examples of significant findings noted in these stroke patients and a take-home message. As we all know, this is published in Science very early in pandemic that it's a rampage through the body, which where lungs are ground zero, but it can affect any part and any organ system of the body. In the very early phases of COVID-19 pandemic, there was quite a high prevalence of thrombotic events, not only in patients with severe COVID-19 infections, but also in patients. During the last year, in the beginning of the pandemic, we started noticing interesting findings. The emergency visits to hospitals reduced after the lockdown. Then there are surgical emergencies significantly dropped down. This is a paper from Italy, where there's a reduction in number of acute surgeries. Then it was also noticed that about a third of patients have unexplained deaths, mainly cardiovascular. This is a analysis which is reported that in patients in hospitals where this is a study from China, where in the early weeks of pandemic, it was noticed that as the number of pandemic cases increase, there is a significant drop in the number of ischemic and hemorrhagic strokes. And it also showed that there is a significant drop in thrombectomies in during this time while the patients were being hospitalized for COVID infections. We also noted similar change. We published this in June 2020, that this is the pre-pandemic time where, as you can see at Hamburg General Hospital, the average number of stroke admissions in our institution. And during the first 3 months of pandemic, as you can see, there's a significant drop in total number of suspected stroke admissions. Later, we figured out that although it was noted that the ischemic stroke increased during this time, but this was actually because of the drop of reduced number of TIAs and stroke mimics coming to the hospital as compared to increase in ischemic or hemorrhagic strokes. Then this is the analysis from the time when the pre-pandemic time till the pandemic time. There are 2 COVID waves happened until May in state of Qatar. As you can see, during the first wave, the admissions in the service significantly dropped. Now with some reduction in ischemic stroke as well, but there is a significant reduction in the stroke mimics and TIAs. But after the first wave and during the convalescent period and the second wave, when it hit in January 2021, we did not notice any significant drop in the number of ischemic strokes as compared to the first wave. So these are interesting findings which we noted in the time of first and second wave. Very early during the pandemic time, it was this is the first major large vessel stroke paper presented from China, published in NEJM, that showed that patients with COVID infections can stroke. If you look at the most important finding in this paper is, which I thought, is that these patients with large vessel stroke, if you look at their COVID symptoms, they had very mild symptoms related to COVID. So these are not just a severe COVID stroke, which was published before that. These are large vessel strokes with very mild COVID symptoms, which was noted at that time. We also noted that not just a stroke, but there are other neurologic symptoms, neurologic conditions like cerebral venous sinus thrombosis, encephalopathy, encephalitis, meningitis, and peripheral neuropathies and GBS, also noted in patients with COVID-related infections. COVID, it proved that COVID not only affects other systems of the body, but it does cerebrovascular and neurologic manifestations of such patients. If you look at another publication, it showed that that severity of COVID it's not necessarily related to neurologic deficits. It can affect equally in patients with milder form of COVID as well. That these patients can present with severe neurologic symptoms. And neurologic symptoms in about 20% of patients can be the first manifestation of COVID infection as well. Along with that, if you look at this paper, stroke-related deaths were noted to be quite low as compared to pulmonary symptoms. This is another paper with COVID-related different incidence of a stroke from different parts of the world. As you can see, most of the time, the incidence of a stroke was described between 1 to 2.5 to 3% in COVID-related infections. Studies. This is an analysis which is reported from UK. It's a multi-center case control study. They showed that patients who have COVID-related stroke they not only have severe strokes on admission, they have increased hypercoagulability, which is sustained over the period of time. They have significant large vessel occlusions as compared to patients who do not have COVID, and they have worse outcomes at the time of discharge as compared to we this is just to show you that another interesting finding reported in a patient who's 66 years old with COVID lung infection and acute stroke. As you can see that the CT angio in this patient showing a floating thrombus intraluminal in the large common carotid artery. This is an unusual finding which is noted in more which we also noted in our population. I'll show you some patients at the later part of my presentation. We also reported in an early part in last year about a couple of about a number of stroke patients who we this is a study of 32 stroke COVID positive patients, and we noted as compared to, and we compared it with our historical strokes in the pre-pandemic time, and we noted that patients who develop stroke with COVID infections, they are more younger as compared to non-COVID patients. They have less incidences of vascular risk factors. They are more cortical strokes as compared to non-COVID patients or pre-pandemic patients. In our, we have a database, so we have more than 14,000 patients in our database. So we compared them with the pre-pandemic stroke patients. These patients with COVID infections have more severe stroke on admission as compared to pre-pandemic patients, and they have more prolonged hospitalization, and their prognosis is more as compared to pandemic patients. Although in other literature, it has been shown that this is a pooled analysis of 4 studies which showed that the risk of a stroke increases with COVID infection, but there is no statistically significant association with mortality in patients with COVID infection. So different regions of the world have different experiences with COVID-related strokes. And what happens with happened with patients who have COVID infections and intervention? There are as we know that thrombolysis and thrombectomy are timely dependent. Patients who with COVID infections and ischemic stroke, they have been reported to have more poor clinical and neurological outcome than non-COVID patients. And urgent prothrombotic conditions in COVID-19 infection. The contributing factor for these poor outcomes could be late presentation of these patients, and due to the logistics of handling the COVID-19 precautions, which could have further delayed the presentation and treatment. A higher NIH score, tendency to have more large vessel involvement, and multi-system complications related to COVID infection could all be contributing factors in the poor prognosis of such patients. There is a series of 4 patients who also developed catastrophic hemorrhage with IV thrombolysis, which could be suggesting that COVID and stroke might put the patients at a higher risk of bleeding. So these are experiences which is published in the literature about patients and stroke. I will just briefly touch about the mechanisms. Up till now, we have different variants have been reported, which has affected the different presentations in the and mechanisms of conditions in stroke patients. There are usually four possible pathophysiologic mechanisms have been described in causing a stroke in COVID-19 patients. These are either immune-mediated thrombosis and hypercoagulability related to virus, which causes platelet activation and leads to thrombin activation. The other mechanism which is described is renin-angiotensin to constriction, inflammation, oxidative stress, and proliferation of thrombosis. Then there are cardioembolic mechanisms, which is associated with ischemic cardiopathy, which can lead to not only acute coronary syndrome, but also to ventricular dysfunction. There are arrhythmias reported with this, and significant myocarditis and cardiopathy, which could lead to further cardioembolic source and further embolic strokes. Then there are damage to the neurovascular unit also described due to the inflammation of the endothelial lining of the blood vessels, which leads to microvascular thrombosis and blood-brain barrier disruption. This is more associated with intracerebral hemorrhage. So now here I will tell you, I will share with you our experience with a pandemic and a stroke related to COVID infection. Before talking, I just want to briefly tell you about how the health system in Qatar works, especially with the stroke service. So basically, Hamad Medical Corporation is a combined corporation of 8 hospitals and home health care and ambulance services, which are all accredited by Joint Commission International. Hamad General Hospital is a main tertiary care hospital, which is a primary stroke center for all suspected stroke within 8 hours are brought directly with lights and sirens to Hamad General Hospital. Then there are 3 other sister hospitals which can receive after 8 hours suspected stroke patients, and once evaluated, they can be transferred to General Hospital further investigation and treatment. Acute stroke care at Hamad General is 24/7 capable of interventional thrombectomy, thrombolysis, and stroke ward care. We have a multidisciplinary team which takes care of stroke patients on a daily basis through a protocol-driven care. We have a state-of-art stroke rehab institute where all our stroke patients who need further rehabilitation are transferred after initial management. And we have a stroke database which helps us in maintaining the guidelines and the key performance indicators and quality care, and also helps in finding out the outcome of our management and helps us in doing research as well. Our patient journey happens in Hamad General Hospital. If a suspected stroke patient, most of the time, if a patient is picked up with hotline which alerts us to activate the stroke protocol, and patient goes for the CT. We actually, I understand Dr. Götz's point about advanced imaging. At present, our protocol does the whole CT protocol, including CT perfusion in every suspected stroke patients. The concern is that a lot of our population is a single, and sometimes we do not have very clear time of onset. So in order to reduce the time of management, we do the complete protocol of patients, including CT angio and CT perfusion. Unless the plain CT shows only acute hemorrhage, the complete protocol is done. So if it's a hemorrhagic stroke, patients neurosurgery case is transferred to neurosurgery. Otherwise, the patient is admitted to stroke unit. If it's ischemic stroke, patient is assessed for thrombolysis and thrombectomy by the stroke team, which is 24/7 in the hospital. Patient is admitted to the stroke ward, or if patient is admitted to medical unit, if he is a minor stroke and not a candidate, patients are then once managed, they are discharged home to rehab or long-term care. In patients, all patients with suspected stroke, they are evaluated by the stroke team. They go for CT protocol. ICU, they are admitted in ICU only if they have decreased level of consciousness, or they have complication after the procedure, or if they need intra-arterial medications. Cerebral hemorrhage is admitted in neurosurgery only if there is posterior fossa bleed with mass effect, or intracerebral hemorrhage uncontrolled pressure, with medication and undergoing neurosurgical intervention. So these patients are admitted in neurosurgery. Otherwise, a stroke team manages all these intracerebral hemorrhages. This is the present situation 3 days back in the state of Qatar. We have vaccinated 90% of our population have received first dose of vaccination, and 80% have received almost between 75 to 80% have received 2 doses of vaccination. After the second dose, we have a very significant control on COVID-related infections. This is, you can see, there are 2 peaks which happened over the period of time since last March up till now. The first case happened on 28th February 2020, and the second peak happened in the later part of mid-January to peaked in April, and then now it has gone back. Mortality, as like any other place, the number of mortalities in the is very less as compared to the number of infections. So what did we do when a pandemic started? The 4 major hospitals were recognized as COVID hospitals for acute and critical management of COVID-related cases. 3 major centers started to for patients with COVID PCR positive status and symptomatic care. They started providing them. Later, 6 more hospitals were added for active and symptomatic management of patients. 25 quarantine centers were created for asymptomatic patients, while Hamad General Hospital still remain the primary center for all suspected stroke, whether they were COVID positive or not, or not positive. All stroke patients, acute suspected stroke, were transferred immediately to they arrive. They were kept in a high acuity area. All sub-acute strokes were admitted to non-urgent areas. Each patient during pandemic was examined by the ED physician and neurologist through the proper PPE and N95 masks, and each patient was questioned about febrile illness and upper respiratory tract symptoms. Everybody gets a chest X-ray. CT chest, we tried to consider doing CT chest on each patient who were going for a CT protocol, but we could not convince our emergency colleagues and administration of doing CT chest on every patient. So we have a limited number of CT chests on these patients at the time of initial evaluation. Then PCR was with the suspected stroke. If the patient is a known COVID positive, he has a on different floor for COVID positive patients to do a CT protocol for acute stroke. One-to-one nursing is done on every stroke patient at that time until it is clear that they are not COVID positive. Minimal contact was maintained. Thrombolysis was done as protocol, and interventional thrombectomy. They also were provided with proper PPE and protective measures. And post-thrombectomy or large strokes, we admitted all these patients to medical ICU at that time rather than a stroke ward. Patients with rehab potential and post-thrombolysis were admitted to the stroke ward. If the patient turns out to be COVID positive, he was isolated in a separate room in the stroke ward. And once the acute care is done, they were transferred to other hospital for further stroke management. And we transferred 2 of our stroke neurologists to another hospital. So strokes after initial management to those the hospital where the stroke neurologist can take care of further take care of these patients. How the pandemic affected the stroke service? There was a redistribution of physicians, nurses, therapists, and pharmacists to other hospitals because of increasing number of COVID infections. So that's why maintaining key performance indicators during acute stroke care, that is door-to-needle time, length of stay, delays in transfer, were noted at that time. Stroke ward care showed delayed admission because they have to wait for 8 to 10 hours for the COVID testing because we were admitting only COVID negative patients in a stroke ward. Reduced number of staff and post-intervention cases delayed because of pandemic going on. Patient disposition to the rehab, follow-ups, and ICU. These all entities were affected because of COVID. Obviously, because of redistribution of staff, the workload on the staff remaining in Hamburg Hospital was significant, and they were burned out as well with the increasing number of patients. We had a TIA clinic, we call it a rapid access stroke unit, where we were seeing TIAs and non-dislabeling strokes after initial emergency management. We had to close this unit because the OPDs were closed in the especially in the first phase, so all these what happened is that we have to after closing this, and they unnecessarily stayed in the hospital because we could not discharge them without proper investigations. Also, because of their unnecessary stay, there was a possibility that they could be exposed to COVID positive surrounding. Investigations which could have been done in a stroke clinic, like carotid Dopplers, Holter 24-hour blood pressure monitoring, and echo, they were stopped because of the closure of the OPD. Telephone consultations were started for follow-ups at a stroke clinic, which obviously did not provide complete evaluation and patient satisfaction. So these were the challenges we faced during the COVID pandemic, and now as things are slowly opening up, things are resuming back to towards normality to some extent at least. So we did notice that there was a significant delay in door-to-needle time and sticking to the protective measures. Patients with thrombolysis and thrombectomy usually before pandemic were admitted to stroke wards, but during pandemic we were admitting them in ICU, which affected the route of to follow the stroke pathway. Patients who were confirmed COVID positive and stroke, they were transferred to other hospital because Hamburg General Hospital was only admitting COVID negative patients in the inpatient areas, so these strokes were transferred to other hospital who do not have focused stroke service over there. So that also could have affected stroke care. Admissions in such places in those hospitals who do not have specialized stroke related therapists. So we also in those halls, we stopped our multidisciplinary meetings because of the COVID-related restriction of meetings, and this led to delays in communication, writing plan of care, and transfers. Now here I'm going to show you what is our experience, what type of patients we saw in COVID-related pandemic. So we, up till now, until July 2021, from March 2020, we have confirmed 151 patients who were diagnosed as having stroke related conditions. So we evaluated these patients. We divided them into two groups, that patients with active COVID infection and patients with who developed a stroke after active COVID infection. And active people 19 positivity. We evaluated these data, and I'm going to share this data with you. This is an unpublished data. We are planning to submit it very soon. So we divided this into two groups: patients with active, which is 62 patients, and patients which is without active, which is 62 patients, and patients with active COVID, 89 patients. As you can see, ischemic stroke was more common as compared to inactive COVID infection, as compared to hemorrhagic strokes. The most important thing which is noted is that there is a significant number of large vessel disease, usually in the MENA region, and along also in Qatar. We have more of small vessel disease as compared to large vessel disease in the Western population. So we will if we usually have 40% of our strokes are small vessel disease. But in COVID-related infections, we noted a significant number of large vessel and cardiomorphic disease as compared to small vessel disease. As you can see here, only 15%. The only risk factor which was significantly different between these two groups was that in patients without active COVID infection, they were more hypertensive as compared. Otherwise, the risk factors were not very different in these two groups. There is no significant difference in the COVID-related symptoms, fever, abdominal pain, not different in both these groups. But you can see that there is a significantly severe stroke in active patients with active COVID, even if you divide them into different NIH severity. More severe strokes as compared to patients with inactive COVID. They stayed more longer in a hospital as compared to inactive COVID, and their NIH discharge was also significant. There's no differences between the use of oxygen, pneumonia on admission, symptomatic COVID on admission, and oxygen inhalation required. The only difference which we noted is that patients with active COVID, they have more clear chest X-rays at the beginning on admission as compared to patients without active COVID infection. And patients with active COVID, they were more frequently intubated COVID, and they stayed significantly more number of days in ICU as compared to inactive COVID. The number of different laboratory parameters, the only thing which we noted any significant difference is that the CRP level was significantly higher in patients with active COVID as compared to inactive COVID. Along with that, if you look at CRP more than 5, it was significantly higher in patients with active COVID, and the CT value of COVID PCR was significantly higher in patients with active COVID as compared to inactive COVID. Prognosis in patients with active COVID, as you can see, that they have more poor prognosis at the time of discharge as compared to inactive COVID. Also, although it was not statistically significant at the time at 3 months. Was not very statistically significant in these two groups. This is to describe different vascular therapies, which, as you can see, more large vessel is involved in patients with active COVID as compared to inactive COVID, but it was not statistically significant. The thing which I want to show you is that there is a significant, as I told you from before, we do have a lot of small vessel disease in our region. But if you see, there is a significant number of extracranial thrombus present in our patients with active COVID infection, between 21%, and it shows a trend, although it was not statistically there is a higher of extracranial thrombus present in patients with active COVID infection. Here, I'll show you a couple of cases which with this. This is a 49-year-old patient with diabetes who came with the 12th day of COVID infection. Here you can see clearly that in patient with a, this is the same as I showed you the case which is reported before, common carotid showing a large vessel thrombus in one of our patients with the active COVID infection. This is another patient of 66 years old. You can see a large thrombus in the aorta of a patient with active COVID infection. This is another patient with a complete common carotid, and the whole carotid system is occluded, as you can see here in the common carotid as well. This is the type of strokes we usually not commonly see. Here also there is another one with a common carotid occlusion. These are the types of stroke which we commonly have not seen. I've been practicing stroke here and for the last 16 years in Middle East. Such a number of large vessel thrombosis in our stroke population, no matter which nationality or race they are from. But in COVID, we have seen a significant number of patients with large vessel thrombosis. So I will conclude my talk here with the following points that since the pandemic, there is a substantial proportion of COVID-19 patients who have documented thrombotic complications and ischemic stroke. There are several mechanisms already described which can lead to thrombosis in these patients with cardiovascular and cerebrovascular disease. So there are simultaneously, because of the significant strain on global healthcare delivery, including stroke management, have made treatment of a stroke in this setting of COVID-19 particularly challenging. Can address different complications and care to such patients. However, until we have a global vaccination and immunization being achieved, the burden of COVID-19 effect will be apparent on our everyday practice. Medical personnel should maintain a high index of suspicion for stroke symptoms among COVID-19 patients to make sure that timely revascularization of treatment of acute ischemic stroke, especially with large vessel occlusions, as timely reperfusion is one of the main factors which can help in improving the functional decline and death in such patients. Due to the accumulating evidence on the potential direct correlation of COVID-19 and cardiovascular events of a stroke, the treating physician should be alerted for any potential signs of COVID infection, because as we have seen that no specific signs and symptoms of the disease specified, and most patients can be asymptomatic while they present with acute cerebrovascular event. Thank you so much.
Thank you, Dr. Naveed. It was a pleasure to hear your experience and the numbers which is coming from Qatar, and wish everyone at the level of the region and the globe to go back to the normal life and to meet face to face. There's many questions. If I will ask Dr. Naveed and Professor Götz to be with us. So as you notice that there's plenty of questions, so we will try to be brief in our answer. And so we'll start with the first question with Professor Thomalla. I need to ask, what's your personal experience of giving TPA in a wake-up stroke and extended window? I mean the outcome of your patients. Professor Thomalla, you went through this one. Any comments?
Yeah, well, my experience, it's very much the same like with TPA anyway in the known time window. We have patients which really have a fantastic outcome. They come with a severe hemiparesis and have virtually no symptoms. But of course, there are patients which do not benefit that strong. But there's no difference to the known time window.
Excellent. And that's what we had recently. One patient who came with a woke-up stroke, CT brain was normal. And when we did the MRI, which is good thought by one of our junior doctor, as you mentioned in your talk, doctor, and it showed that there's a thalamic stroke in that patient who came with very weird presentation, dizziness, screw deviation, and sensory complaints. So TPA was given, and he had a good recovery within 24 hours. Another questions, Professor Thomalla. As W suggested, that's a little bit neuroradiology question, as the DWI images suggests cytotoxic edema. Is this not the core? The patient is asking, is these highlight or hyperintense signal on DWI is the core ischemia? Does the absence of layer abnormality indicate only the potential time for infarction, or does not reflect the penumbra? Is that correct?
So what is correct is DWI shows the cytotoxic edema, which is for practical management very much the same like the infarct core. I mean, there are reports of DWI normalization, but for practical usage, it's like the core. So this is tissue that is already dead. And the DWI flare mismatch does not show penumbra. That's absolutely correct. It shows the time. And of course, flare shows the irreversible, the finally irreversible tissue damage.
Interesting. Dr. Naveed, in the early stage of COVID, we noticed that there's a huge drop in the number of TIA and minor stroke in different centers, and many papers came, WHO spoke about this to increase the awareness. Is this still going in Qatar, and why do you think that we had it in very early stage, then it has been improved?
No, I think the situation has normalized. As you remember, if you remember, I showed a slide of extended period of time that the numbers of coming to our emergency has reached to the same baseline as it was before. I think at the beginning when the pandemic was there, people were more concerned about getting the COVID infection rather than a patient with minor symptoms. And this is a worldwide phenomenon. There are multiple papers from every region has been described that there is a significant drop in visits to the emergency. So patients with a stroke, minor stroke, and stroke mimics, they were noted not to coming to hospital, and they stayed at home. They contacted physicians on phone. That's why the virtual clinics gained access and so popularity, because most of the patients, because their symptoms resolved over the period of time also, so they thought that it is better to contact through virtually and get the expert opinion. But I think now as the pandemic is settling in most of the regions, with better vaccination and better understanding of the disease process and safety protocols, the number is normalized over the period of time. But initial scare was there. People were concerned, and most of the people were concerned that if they come to the hospital, they will get a COVID infection. So that concern was there as at that time, which has led to significant drop plus there were significant health care officials and administrations also notified that to the patients and the families that please do not visit emergency if it is not an acute emergency, because it will affect the care of other patients. So there are multiple factors at that time which led to decrease in number of patient visit to emergency. But I think over the period of time after the second wave, things have come back to the baseline, and we are seeing again the same number of patients which we were seeing in the pandemic time.
Okay, thank you, Dr. Naveed. We are losing your voice for a fraction of a second. If you can change your position, it will be good, Naveed, because we are losing the net in between.
Sorry.
Yeah, so Prof. Thomalla, there's a question from Dr. Muhammad. In the wakeup trial, patients with WI and flare mismatch with a large visual occlusion, do we go to IVTPA, then thrombectomy, or we go directly to thrombectomy?
So in the wakeup trial, we only did IVTPA, as I mentioned, because we did not have thrombectomy available. And for practical reasons, I would say immediately give IVTPA and then go to a mechanical thrombectomy unless there's a contraindication against IVTPA. But there's no reason to withhold IVTPA in these patients.
Sure. There's another question from Dr. Rakan. He's saying, number one, rule of heparin in acute stroke. Question number two, best approach for basilar occlusion.
So there's no role of heparin. All the trials that used heparin acute stroke showed an increased risk of hemorrhage and no benefit. So it absolutely has no role, only for prevention of thrombosis in a low dose. And this is very clear, I think. And yeah, for basilar artery stroke, that's difficult. I mean, you may know the results of the randomized trial, which of course they have their problems, which could not show a clear benefit of intravenous of thrombectomy. But anyway, I think there is a strong consensus that for patients with severe symptoms and a basilar artery stroke, reopening the vessel as soon as possible is the effective treatment. So it may save lives and may prevent disability. So I would always go for mechanical thrombectomy if possible.
Agree. There's always a challenge, Prof. Thomalla, with the basilar stenosis, that we will have it while we are doing the procedure, or having the dissection, which is a rare entity, but it's also one of the causes for the acute stroke symptoms. So how can we differentiate between acute embolic stroke basilar, stenosis, dissection? Is there any neuroimaging, or it's very challenging?
I think it is challenging. So sometimes the location of the occlusion helps a bit understanding if it's an embolic occlusion or it's rather a pre-existing stenosis. But in the end, you only know if you try to open the vessel and if the vessel is fine afterwards, or if a stenosis remains. So, and in the end, it doesn't matter for treatment. You would give IV-TPA to both, and you would try to get the thrombus out there by thrombectomy in both situations.
Sure. Now I will go for a few questions which just came as a debate. Dr. Naveed, vaccination and stroke. Any thought about it? I had few patients who just had their vaccinated few hours ago or a week ago, and they came with an acute stroke, and everyone will claim or blame the vaccination for that.
You know, this is a very interesting topic, and as you might be aware that we are actually looking into that. I have about a good number of patients who have suffered stroke after vaccination. There are some literature described the vaccination-related thrombosis. The activity period is between 3 to 28 days. So I do not have, you know, we are still working on our data, so I cannot prove it by a data, but there are some interest growing in this regard, that is vaccination of it related with stroke or not. I can say that I can tell you that I have about 45 to 50 patients who have suffered a stroke between 3 to 28 days. But I have to evaluate their data to understand whether they have regular risk factors. Is there any statistically significant data to support this notion? I don't know. I cannot say that right now. But once we evaluate that data, we will look into that and we'll publish it and see is there any real evidence or not. Because you know there are a lot of speculations. I am a very pro to vaccination. I believe that the only way we can fight with this pandemic is that we vaccinate our community as soon as possible. But you know, wherever the science evidence comes, it is our responsibility to share that evidence also. So we are working on that, and I know that there are some interest in the region as well, and I'm working with my colleagues that if we can have a combined sharing of data with the combined publication, if we can come up with that, that would be a huge benefit to the literature.
Professor Thomalla, do you prefer for those wake-up stroke or unknown timing to do CT, CTA, CT perfusion, or to go direct for MRI, the WI mismatch, or MRI perfusion?
Well, as I mentioned, it depends. It depends, of course, if we have both available and we have a rather minor, moderately severely affected stroke, I would also do MRI. But if we have a very severe stroke and it's likely that it has a large vessel occlusion, I would do CT perfusion and CT angiography, because it's usually faster, and we will see a large vessel occlusion, and then we have the patterns available to decide both for TPA and for thrombectomy.
Interest. Many questions is coming. Another large debate questions, Professor Thomalla. TNK versus TPA. And non-mechanical, we know that there's a large 2 trials came regarding the mechanical with TNK. How about those patients whose wake-up stroke, unknown time with a TNK?
So there is no clinical trial that ever showed that TNK is better or even very non-inferior to alteplase. So we believe this because we know the pharmacological properties, but there is no trial data. So I would always recommend to use alteplase until we have a trial that really shows that TNK is maybe better or non-inferior. The problem is we don't even know the best dose of TNK. You may know that there are several trials which use different doses.
Agree.
And there are some advantages. You have just to give a bolus and no infusion, but I would not give it at the moment. I think there are too many open questions.
Agree. And do we need to go through the same exercise like we did with the alteplase, with the TNK regarding wake-up stroke trials then we need unknown time, then we need to do the windows timing to 4.5, 3 hours. Do we need to go through all those 25 years?
No, I don't think so. I think we just need one robust trial which shows no matter in which population, the TNK is very much the same like alteplase, or maybe even better, but we need this trial. And for example, the large NOR-TEST trial, which used TNK, was not very convincing. And the only very convincing trial is when TNK was given prior to thrombectomy in the Australian Extend-IA trial. Yeah.
Sure. Thank you. Dr. Naveed, I think Dr. Mustafa is asking, when do you recommend patients to go for a vaccination after a stroke? It seems a patient who didn't receive the vaccination, he had a stroke. So when do you recommend them to go for the vaccination?
Dr. Suhail, I seriously don't know the right answer for that. I am not sure if, because patients who develop a stroke usually, in this in our population have risk factors. Okay, so like patients who go for a surgery after a stroke, patients who go for any other medical procedure, it is usually recommended between after 4 to 6 weeks. So if I can use that information or evidence, but as such, I do not know. Probably an ID consultant might be a better person to answer. Do not know the right answer for that. That's all that.
Okay. Last question for Dr. Naveed regarding how did you manage to do the stroke workup, like echo, carotid Doppler, physiotherapy, rehab in those patients stroke with the COVID?
Yeah, so as I mentioned that we kept our patients in emergency until their COVID test came negative. Okay, so they were thrombolized and thrombectomy. If they were thrombolized and thrombectomy, they were going to the ICU. ICU has a specific area for COVID-related patients only. So they were managed over there. Patients who were coming to stroke ward, they were all COVID negative. So once they were COVID negative, so there was a delay for 8 to 10 hours until the results come back. Regular investigation. Patients who turned out to be COVID positive, they were sent to another hospital, which is for active COVID-related specialist hospital, who were managing a stroke, MI, COVID-related other, sepsis, other problems. So that hospital was only for COVID-related complicated patients. So all stroke patients after initial management of thrombolysis and thrombectomy, if they have received thrombolysis and thrombectomy, they have to wait for 24 hours in our hospital because that hospital does not have neurosurgical capabilities. So we have to keep them for 24 hours, and then that hospital has their echo and other investigation available for COVID patients. So we separated COVID and non-COVID patients, okay, after in the emergency. This patient will be disposed. So all COVID negative will be admitted and all COVID positive will be sent after initial management to the hospital.
Sure. So we are reaching the end. So I would like to ask all our audience that you will receive your CME within 2 weeks after this presentation or this webinar. I would like to thanks at the end Professor Thomalla for his presentation today, and he spoke about the extended window for thrombolysis in wake-up stroke and in unknown time. He went through a literature review, and he gave us 2 cases that discussed the different presentation. Then we had Professor Naveed Akhtar from Qatar, who spoke about the COVID experience in Doha, and where he's presented their own data and the publication which came with the COVID era. There will be 2 CME hours will be sent to all the attendees. If you have any issue, please email MCO for getting your the 2-hour CME, but usually it should be on your email within 2 weeks. At the end, I would like to thanks our partner, Boehringer Ingelheim and Medtronic, for supporting these type of activity, and wish you a great night. Thank you, Naveed. Thank you, Professor Thomalla.